Good evening. We are starting the last session today. And the first speaker, I have the honor to introduce Dr. Bruce Miller. Dr. Miller is the director of the Memory and Aging Center in UCSF, and he is one of the referents in frontotemporal dementia. And today he's going to talk about a panoramic view of this disease, frontotemporal dementia. Unfortunately, Dr. Miller was not able to come, but he recorded his presentation.
Buenos días, me llamo Bruce Miller y muchas gracias a mi amigo Pascal Sánchez para la oportunidad de hablar a ustedes acerca de frontotemporal dementia y muchas gracias a la reina de España también. Okay, I am going to speak in English about frontotemporal dementia from diagnosis to treatment. An overview, I will talk about modern subtyping, molecules, pathology, genes. I'm going to emphasize what a burden to caregivers the psychiatric manifestations of this disease make. Following that, I will give a brief clinical overview of frontotemporal dementia, talking about biomarkers, lifestyle as a potential treatment, and a little bit talking about how basic science is going to change our treatments for these degenerative diseases. So frontotemporal dementia is associated with three major clinical syndromes: behavioral variant frontotemporal dementia. When we see that syndrome, we see bilateral frontotemporal atrophy, also involvement of the basal ganglia. Many BVFTD or behavioral variant cases are genetic. Approximately 1/2 of cases are caused by tau aggregation. The other half are associated with TDP-43. The language variants, which almost by definition affect the left side of the brain more than the right, have two different clinical and imaging syndromes. The semantic variant, which affects the anterior temporal lobe, and the amygdala, which you can see here is absent in this image, is very focal. It involves the temporal lobes much more strongly than the frontal lobes. It is rarely genetic, and when it is genetic, it is almost always caused by a mutation in TDP. About 85% of the cases that we have with this variant are pathologically associated with TDP-43 type C aggregates. Non-fluent variant, a very different pathologic clinical story. This affects the left frontal opercular region asymmetrically. Some cases are genetic. When it is genetic, it is usually associated with TDP-A pathology and progranulin mutations. Most of the cases, though, are caused by tau. 85% of the cases in our brain bank at UCSF are associated with tau, and at least 50% of our cases are associated with cortical basal degeneration pathology. Three different syndromes, three different anatomies, different sets of genes, and different pathology. This is just a quick summary of the tauopathies, classic Pick's disease with 3R tau inclusions. PSP and cortical basal degeneration are 4R tauopathies with slightly different histological aggregates, slightly different clinical presentations. But I emphasize that most cases of PSP and cortical basal degeneration present with an FTD syndrome. The TDP group is almost always associated with progranulin. B, almost always associated with motor neuron or ALS, and TDPC, almost always associated with the temporal lobe degeneration that I described in the previous slide. A rare cause for frontotemporal dementia is changes in the FUS or FUS protein. Most of these cases with FUS present with very early onset psychosis and behavioral variant frontotemporal dementia, most always considered psychiatric initially. Also emphasize that chronic traumatic encephalopathy caused by repetitive head injury, most prominent in our National Football League football players, is a tauopathy. This is Anne McKee's work. It shows massive aggregates of tau around blood vessels in parts of the brain that are subjected to traumatic brain injury. Also clinically, very often presents as a FTD or behavioral variant phenotype. I emphasize coexisting pathologies, which I think is increasingly evident in our national Alzheimer's brain banks. So the punchline here is that if you are diagnosed with Alzheimer's disease, you often, particularly if you are older, which is demonstrated in this slide, show evidence for TDP-43 in addition to the Alzheimer pathology. Is this clinically relevant? Yes. It makes clinical presentation more severe, definitely associated with the clinical presentation. And I think it's brought up the question, is TDP-43 form of frontotemporal dementia a major cause for clinical syndromes in people over the age of 80? So stay tuned. This is an active debate, but there's no doubt that we are expanding the number of entities associated with FTD pathology. Psychiatry and caregiver burden. When I first started looking at patients with FTD, I realized that it was often the caregiver who died before the patient. And this made me realize that the burden on caregivers associated with this disease is profound. Why? Well, this is a study that was done by Alice Waugh with the Bob Levinson Laboratory. And what they did is they looked at a number of patients with dementia, including those with frontotemporal dementia, asked the question, does atrophy in the patient's brain correlate in any way with caregiver psychopathology or psychiatric illness or global health? So what they found, and this shows this dramatically, is that if you have, the patient has frontotemporal dementia, you see much more severe caregiver psychopathology, caregiver global health. And I also believe in some cases, this accelerates the death of caregivers. So incredibly savage disease as it affects the family and caregivers. What are the consequences of behavioral symptoms in frontotemporal dementia? I mentioned caregiver stress also affects, I think, the professionals looking after these patients for whom we often have no easy answers. It may endanger the individual, the caregiver. It reduces quality of care and life for both. It accelerates functional decline and increases the likelihood of higher risk of placement in a more restrictive setting. And it also increases the risk of chemical restraint with concomitant side effects, including death. What do we do about this? Identify the problem, make a decision about whether it should be treated. Consider not just the patient, but consider the caregiver and their family. Try environmental interventions first. We have care ecosystem at UCSF, where patients are and their loved ones are connected continuously to someone who looks after their health. I asked the question, is the deficit due to a loss of serotonin, in which case certain antidepressants may be helpful. Clinical overview. What does this look like to the clinician? Just a broad description. Alzheimer's disease often begins as a cognitive disorder. We also know that the Parkinsonian dementias begin with changes in not just movement, but sleep, depression, anxiety, and changes in the autonomic nervous system. BVFTD begins with behavior. Although there are executive losses that eventually emerge in BVFTD, I think I am very reluctant to make a diagnosis of BVFTD unless there are profound changes in behavior as early manifestations of the disease. I point out that Alzheimer's disease and Parkinsonian dementias can be associated with executive loss. So beware the diagnosis of FTD when there is only executive loss and no behavior. Image of these patients are often diagnostic to you clinicians at the bedside. You will see focal, frontal, and temporal atrophy, as well as atrophy in the thalamus and basal ganglia. The only exception to this are patients in whom there is concomitant ALS. In those cases, the atrophy may be slightly more subtle. This determines a lot clinically what you do. If you make a diagnosis of FTD, which I think you can do without many biomarkers except for MRI at the bedside, antidepressants are useful, but avoid other psychoactive compounds like the atypicals, and more important, avoid the cholinesterase inhibitors, which help people with Alzheimer's and the Parkinson disorders. Here are clinical criteria for BVFTD. A remarkable clinical criteria. You need 3 of the first 6 clinical symptoms to have possible BVFTD. All psychiatric, disinhibition, apathy, loss of empathy, perseverative stereotyped or compulsive behaviors, overeating, and executive loss with visuospatial sparing. Most of our cases have 5 or at least 4 of these 6 criteria that make possible. If you want probable criteria, you require evidence of atrophy on the MRI or hypometabolism with PET. To get a definite diagnosis, you require a known mutation in addition to possible criteria. Biomarkers, where are we going? Well, I think at least 10, possibly 15% of patients with FTD will have one of these 3 major genetic mutations. MAPT or tau mutations discovered in 1998, associated with abnormal aggregation of the tau protein. How do we prevent this form of frontotemporal dementia? We figure out a way of turning off or degrading tau. I think once we develop this approach with effective ways of doing this and crossing the blood-brain barrier, we will have a prevention for tau mutations. Progranulin mutations, a little older, often very asymmetric, so they present with BVFTD, PPA, and a progranulin mutation increases your susceptibility to Parkinson's and Alzheimer's disease. This is a disease of haploinsufficiency. Too little progranulin leads to the cascade of changes in the brain. We now have 6 companies ready to, with different strategies, replace progranulin, presumably stopping the progression of the disease, and if it's done early enough, preventing its onset. Finally, the C9orf72 mutation, the last one to be discovered, often associated with ALS. Some people BVFTD, some people ALS, some people both. This is pathologically associated with TDP-B and dipeptides in the brain. It is caused by a massive hexanucleotide repeat. The therapy is clear. Turn off the abnormal gene. If you get in early enough, with enough of that gene turned off, you will either stop the disease or slow the progression. I point out that probably another 20–30% of FTD patients have other genetic mutations. This is just a list of some of the genes that we have seen in our brain bank associated with FTD in individuals. I point out that TDP43 often causes anterior temporal lobe degeneration. FUS can present with FTD or ALS. LARC mutations can present with a relatively pure tauopathy. TBK1 is another FTD ALS gene, and so on. So I think the future of precision medicine for frontotemporal dementia will be not only to look for the common mutations, but determine whether this individual has a less common autosomal dominant gene leading to their dementia. Large programs across the United States, of course, Pascal Sanchez is leading major work on frontotemporal dementia in Spain. Also major work being done by Ignacio Elian Gala, many of the people in Barcelona. Also very important work, Carmen Laje in Santander. So just like our longitudinal FTD clinics, you are developing a large cohort in Spain that can follow from the onset of the illness across the disorder, with the idea of understanding how this disease progresses and figure out when and how to intervene in different cases. Like Alzheimer's disease, we have different stages of the illness. Molecular pathology begins many, many decades before the onset of the FTD clinical syndrome. In many cases, a few years before the onset of clinical symptoms, you begin to see losses of brain volume and increases in the axonal protein neurofilament. These are probably going to be very powerful biomarkers for studying the interventions that we hope to do in the early stages of these diseases. Once the behavioral syndrome starts, you see massive atrophy, even over as short as 2 to 3 months. You also see massive elevation of neurofilament. During the course of this progression, we also see evidence of inflammation. So these are the clinical syndromes and the biological biomarkers that we are beginning to think about measuring in this disorder. Just one example, this is work with Pascal Sanchez, Fermain Moreno, Susie Lee, John Van Sweeten. But the story is that before someone with a progranulin mutation develops a clinical syndrome, they start to show hyperconnectivity in the network that they will present with clinically. So if you're going to get non-fluent progressive aphasia, you start to show left opercular prefrontal hyperconnectivity. As the disease progresses, you develop a clinical syndrome and you begin to show atrophy. What an exciting finding. The idea is that we might, when we start to see this hyperconnectivity, begin the appropriate intervention to prevent the progression to hypoconnectivity in a clinical syndrome. Here's the atrophy in a progranulin group of patients. Very little in the asymptomatic individuals, but people who get BVFTD, non-fluent progressive aphasia, even within 8 weeks, are showing measurable changes on brain MRI. We don't yet have a good, powerful biomarker for the tauopathies or the TDPopathies. This just points out that phospho-tau, whatever subtype you use, is very, very effective marker of Alzheimer's disease pathology. These Alzheimer pathologies show no changes in tau, progranulin, or C9 mutations. But stay tuned. I think we are moving in the direction of more specific biomarkers in the blood, also PET biomarkers that will really change our ability to diagnose and follow progression. Neurofilament looks like it's going to be a powerful biomarker for clinical trials. This is beautiful work by Julio Rojas at our center, many collaborators. Punchline is neurofilament in FTD starts to rise very early as the behavioral changes begin, and in the dementia state, massive elevation. Slightly different in the different genetic forms. Progranulin, a fabulous biomarker for disease onset and progression. C9 also, ALS, FTD, powerful biomarker. A little less powerful with MAPT, but there are many other biomarkers that people are looking at to stage the disease and determine whether a treatment is actually effective. Treatment. Just a few words about this. The first is lifestyle seems to moderate the effect of FTD, even in genetic forms. So this was a nice study done by Caitlin Casaletto that showed that if you are cognitively active and carry a gene, you are much less likely to progress than people who are in the lowest 5th percentile in cognitive activity. Being cognitively active is important. Physical activity, again, if you are a very physically active individual, progression is much less likely than people in the low or 5th percentile. How does this work? Well, this is a nice study in Alzheimer's disease where she got a look at, Caitlin, the pathologic correlates of physical activity. And the punchline here is that people who had physical activity went on to die with Alzheimer's and had pathology looked at were less likely to show activated microglia. So the physical activity downgrades the activation of microglia, and this may be a modifiable behavior that helps us to reduce pro-inflammatory microglial states in humans. We've studied a lot in the tau consortium, pure tauopathies. I believe that these may become the first disorders that we have an effective treatment for in neurodegenerative diseases. PSP, cortical basal degeneration, Pick's disease, pure tauopathy. Of course, the mutations are pure tauopathies as well. If we can treat the pure tauopathies of frontotemporal dementia, we may well have a great treatment for the Alzheimer's disease or chronic traumatic encephalopathy syndromes. Tau spreads like a prion, so I think preventing that spread of misfolded tau from one cell to the next is important. In addition, figuring out ways of getting therapy is into the cell that help prevent the spread and aggregation of abnormal tau is the focus of multitude of investigators. I think this shows the promise of the right biomarker for tauopathies. This is a functional connectivity map created by Raquel Gardner and Bill Seeley's lab. It suggests that with PSP, we have a functioning network that involves cerebellum, thalamus, basal ganglia, midbrain, projecting to prefrontal cortex that is dysfunctional because, as we see here, in this PET study caused by the misfolding of tau in these same brain regions. So I think as we get a better tau PET biomarker than the ones that we have now, we will really be able to show whether or not a therapy is slowing the progression of a PSP tauopathy. This is another way of showing this. This shows the PSP network that is disconnected due to tau deposition. And I think the specificity of these changes is remarkable. And I think the therapies will have to be very specific. Treatment of FTD, I've touched on this. We are in the era of treatment, particularly for the genetic forms. Antibody delivery, we may not get enough antibodies into the brain, but this is being tried. We have Claire Cleland at UCSF working with CRISPR to see if we can cut out the bad forms of tau to prevent mutation carriers from developing disease. Very excited about this work. With C9orf72, antisense oligonucleotides, do we get enough of them into the brain? We don't know. Hasn't been a great study of frontotemporal dementia. CRISPR, again, Claire Cleland has taken this field on and is developing very exciting approaches. Of course, small molecules that interfere with the hexanucleotide repeat will also be tried in the coming decade. Granulin may be the most exciting, and the Denali group have shown that they can deliver antibodies via the transferrin receptor that carry progranulin, increasing the delivery of progranulin. Eric Roberson and a number of pharmaceutical groups have shown that they can deliver progranulin through the AAV vector. And then finally, exciting work done with anti-sortilin antibodies to see if we can raise the cellular progranulin and prevent progression of the disease. What an exciting time and what a wonderful opportunity to talk to you at this remarkable conference. Thank you.